All right. Hi, everyone. I'm Richard. I'm the Northern House Student Liaison Officer. I'll just get this webinar underway. It has been recorded, so for anyone who's coming to join us late, you can always just watch the start again, or if there's anything you missed. So the first thing I'd like to do is just do an acknowledgement of country. So Eastern Health and Northern Health acknowledges the Wurundjeri people and others of the Kulin Nation, of which these unceded lands that we work on, and where this webinar is taking place tonight, and particularly with a focus on their culture, of which, and our work towards reconciliation. Special sort of mention to anyone who's joining from an Aboriginal or Torres Strait Islander as well. And we want to pay our respects to the elders, past, present, and emerging. In terms of just some housekeeping for the webinar. So all attendees will be muted. Please type any questions you have in the Q&A box and we'll go through them at the end of every speaker. And the session is being recorded, and then we'll send a copy of the slides to everyone at the end. Cool. And we've got an agenda here. So this is the order we're going to have. We're going to have a bit of Q&A after every speaker. So there'll just be a bit of time for that. So if you guys have any questions, just sort of type them away and I'll go through as many as I can before the end as well. So in terms of the speakers, I'd like to introduce the speakers we've got today. So the first one we've got is Dr. Lauren Sanders, who I've had the pleasure of working with. She's a consultant obstetrician and gynecologist and fertility specialist. She graduated from Melbourne University and completed her training at the Mercy Hospital and Northern Hospital. She then did a 2-year reproductive medicine fellowship at the Royal Women's and gained her master's in reproductive medicine, and with an award of excellence at the end as well. So she's interested in all areas of fertility, including ovulation induction and IVF, general gynecology, and obstetrics. We've also got Dr. Alison Bryant-Smith, who's also a consultant gynecologist who specializes in advanced laparoscopic and hysteroscopic surgery. She also went to Melbourne Uni and then completed her basic training at the Royal Women's Hospital. She then undertook a few years of O&G training in London, and then followed by 2 years advanced laparoscopic fellowship in Sydney with Associate Professor Alan Lamb. She has a special interest in endometriosis and fibroids and loves being a part of the Northern Health laparoscopic gynae team. And last but not least, we've also got Dr. Josephine Vivian Taylor, who I've also had the pleasure of working with. And she's head of gynecology at the Northern Hospital. She's a consultant obstetrician gynecologist and colposcopist. She graduated from Monash University and completed her O&G training at the Royal Women's Hospital, Royal Northfield Hospital in Sydney, and Guy's and St Thomas's in London. She completed her British colposcopy training while in London and is a member of the Australian Society of Colposcopy and Cervical Pathology. So I think the first speaker we've got is Dr. Lauren Sanders on fertility and the new public fertility service. So thank you, Lauren. Thanks for agreeing to be part of this.
Thanks, Richard. Just sharing my screen now. I can see that. So thank you for the opportunity to give you a bit of an update on fertility and where we're at with the public fertility service. So the main things we're going to be looking at tonight is defining what's normal fertility, when for you to reassure your patients and when to refer on. Questions you may be getting asked about how to manage social infertility. What are the key elements of the initial consult, being history, examination and investigation? And also, what will your patient's journey be like through public fertility? So what is normal fertility? So fertility is defined as the ability to reproduce. So infertility is a disease of either the male or female reproductive system, defined by failure to achieve pregnancy after 12 months or more of regular unprotected sexual intercourse. So the time in which most patients will conceive as a couple, by 6 months, 70 to 80% will have conceived. By 12 months, 80 to 90% will have conceived, and that goes up to about 95 within 2 years of trying. But this is with the assumption of regular menstrual cycles, normal anatomy, and normal semen parameters. So as you can see here, the biggest factor from fertility is maternal age. And it's one thing we can't change. So this is a study that looked at fecundability and cumulative pregnancy rates in nulligravid women by age. So pregnancy was determined as a positive pregnancy test, so not actually an ongoing pregnancy, just the presence of a positive beta-HCG. You can see in women below the age of 38, in their first cycle, it's around 20 to 25%. But over the age of 38, and that's where the nadir infertility really drops, down to about 16%, and then significantly further over the age of 40. Whereas if we look at our cumulative pregnancy rates, by 12 months, over 35 years, we say it's around 75%. After 1 year over the age of 40, though, it's between sort of 40 to 50%. And that's just a positive pregnancy test, not a take-home baby, which you can see reflected here. So pregnancy rate and live birth rate are quite aligned in the less than 34 and 34 to 37 age group, but in those older women in the 38 to 42, whilst we're getting positive HCGs, they're not taking babies home. And this is due to our miscarriage rates as well as aneuploidy risk, and that increases significantly as women get older. So what are the main causes of infertility? So it can be a problem with production of sperm and egg. Is there a structure or function of the male or female reproductive system? There can be both hormonal or autoimmune disorders in both patients. The main one being advanced maternal age. Lifestyle factors being really the only significant thing we can impact on. And then erectile and ejaculatory dysfunction. So for females, they're divided primarily into these categories. So ovulatory disorders. So majority of women being those that have polycystic ovarian syndrome, but there is also a smaller group of women with hypogonadal hypogonadism. I always struggle to say that word. Tubal factors in around 40% of women, so women that have had previous self-injectomies for ectopic pregnancies or past history of PID leading to blockage of tubes. There's a small group of women where there'll be uterine factors involved, those that have had polyps, fibroids, septums, adhesions or Ashermans from previous instrumentation of the uterus. And then about 15% of women will have an unexplained cause. In terms of the men, mainly it's due to testicular failure, and that's mainly due to an increase in temperature, those with varicoceles, infections, undescended testes. There's also central pituitary causes that lead to sperm problems, and other causes mainly being genetic related, so cystic fibrosis, YQ microdeletions and Klinefelters. There's also a smaller proportion of men with systemic disease and immune dysfunction that leads to infertility. So in couples where we can't find any reason for their infertility, it's around 10 to 20% of them. It's difficult to say whether or not currently that's reflecting our limitation of our current diagnostic tests. But for a majority of these couples, really something is unmasked when they undergo IVF. And this is seen in failed or poor fertilisation rates, poor quality embryos, recurrent failed implantation, sperm DNA issues, or poor egg quality. Just to touch on social infertility. So I'm sure many of you are having both single women or same-sex couples that are coming to you with a lovely Medicare applied terminology of social infertility. So these are women who wish to conceive but may not have access to sperm. So there is an increase in the accessibility of donor sperm and donor oocytes and also donor embryos. And that is available mainly through the private system, but the public system is establishing a donor bank that will hopefully be utilised in the not too distant future. And these sperm and egg are then for use with IUI or IVF. So I think something that you as GPs are probably well aware of is there's significant fertility misconceptions in the community. And this was a study that was focused on Australian women's knowledge and understanding of their own fertility, and how a GP can role can be critical in helping these women make their informed decisions. So up to 20% of women are unaware of the impact of age on their fertility. 80% overestimated by 5 to 10 years the age at which fertility begins to decline. They appear to be misinformed about the ability of ART to overcome the biological clock. And that's a big thing when people come to see me in clinic. They think, okay, great, I'm seeing an IVF doctor. IVF's going to fix everything. Unfortunately, it's a way of achieving pregnancy, but we can't really do better than Mother Nature does already. Which is there. 60% believe that they were likely to conceive if they used IVF. And there seems to be limited knowledge of the association between fetal abnormality and increasing maternal age. So as you can see, the risk of miscarriage significantly increases with increasing age, especially in the over 40s population. And that mainly aligns with the risk of chromosomal abnormality in these pregnancies. So when these people come to see you, what are the factors to consider in taking your history? So it's mainly around the duration. Consider their age if over 35 for an earlier review. Is it presenting with secondary infertility? Are they trying to conceive again with the same partner? Do they have a history of miscarriages? What's their previous mode of delivery? What might sound like a silly question, and I outline that to all my patients, is taking a sexual history, asking about their timing, their frequency, what are they actually doing? Because a lot of education can happen in that first instance. Are there concerns with erection or ejaculation? Is there lifestyle or BMI changes? And also about family history. Is there a history of developmental delay, recurrent miscarriage, thyroid, diabetes? Things to focus from a female history in particular, I guess, is trying to determine where we focus our energy. Is it an ovulation disorder? Are there tubal or anatomic issues? Or do we think it's related to lifestyle factors, maternal age, it's going to affect poor egg quality or their reserve? Things to look for in examination: have these women reached their general pubertal milestones? Are there signs of androgenization in terms of polycystic ovarian syndrome? Do they present with any pelvic masses or abnormalities? And I guess also from this point of view, opportunistic health screening, and is that up to date? Similar for men, things to focus on in regards to previous prior paternity. Often some of the older men will have had previous families and fathered children in other families, and this is a new onset. There is also asking the question of, have you had a vasectomy? I've had quite a few people that go, oh yeah, I had a vasectomy after my last family, and then have forgotten to actually disclose that following that. All those general questions there, which I'm sure you're all taking. Same from a male fertility examination. I would suggest that probably as GPs, you do a lot more prostate examinations than I do as a fertility specialist. But the majority being assessing testicular volume and function. But semen analysis is probably the best way to go from that perspective. In terms of what investigations we require from a fertility perspective, but also mainly what you're doing in the community, mainly regarding antenatal serology. Is there something opportunistic that we can be targeting prior to them coming to see us as fertility specialist? We also would recommend that it's a good time to do STI screening, so chlamydia and gonorrhea, especially in younger women. Pelvic ultrasound, whether or not there is something that needs to be assessed from a gynae perspective as well as a fertility perspective, and also AMH. So AMH I'll talk a little bit about further later down the track, and also about the pelvic ultrasound. From a male perspective, semen analysis is very useful. A one-off semen analysis that is abnormal does not necessarily mean that there is ongoing abnormalities. So if they have an abnormal semen analysis, I'm more than happy for you to refer on, but we'd often recommend having a repeat one about 6 to 8 weeks after to see if it's an ongoing abnormality. And also to offer carrier screenings, which is now covered by Medicare. So further fertility targeted investigations being hormone profiles, tubal patency testing, the genetic carrier screenings that I just touched on. So from November last year, thanks to Mackenzie's mission, Medicare are now rebating the 3-gene analysis for cystic fibrosis, Fragile X and spinal muscular atrophy. And all of my patients that seem to come back are in mid-cycle when they're actually getting these results back of late. They are that little bit of a backlog since that is now covered by Medicare, and similar to carrier types for both partners, which is now covered by Medicare for people of reproductive age. Just a little touch on AMH, because I know there are a lot of GPs in the community that are very comfortable with ordering AMHs and some that are a little bit apprehensive. And I really leave it up to you about to whether or not you feel comfortable with ordering AMHs. It's the one test that's not covered by Medicare, so it's about $80 out of pocket to the patient. But it doesn't tell the patient whether or not they're going to get pregnant. So it gives an indication of ovarian reserve, how many eggs they have, but it's not a marker of ovarian quality. So it's produced by the granulosa cells, the preantral and antral follicles. So women with polycystic ovarian syndrome will have a higher AMH due to this fact, but the AMH will also decline rapidly after the age of 35. It can be lowered with women on the pill or with high biotin intake, but it's not affected by other parts throughout the cycle. So as I said, so we see it commonly in women with polycystic ovarian syndrome. It's also useful for an assessment of risk of ovarian hyperstimulation syndrome in the women that go on to have IVF. In our postmenopausal women, it can be a marker of a granulosa cell tumour and useful for markers of dosage of IVF medications. So most of you will probably have seen a graph like this as to the decline. I think the majority of pathology companies will give you a graph similar to this, but mainly with 3, a high, a medium and a low range. So when would we like you to refer? So as I said previously, couples less than 35, we say try to conceive for 12 months. Couples that are over 35 are being tried to conceive for 6 months. Those in a same-sex relationship requiring donor egg, sperm or surrogacy. Patients that are wanting to discuss egg freezing, be it either medical or social fertility preservation. Women with a low AMH. Those that are considering pre-pregnancy counselling, especially women with complex medical histories. We're more than happy to have conversations with them from that point of view. And also women with a history of recurrent miscarriage. Outside of that, indications for early referral in women are those with amenorrhea or oligomenorrhea, previous abdominal or pelvic surgery, a history of polycystic ovarian syndrome or endometriosis, a history of pelvic inflammatory disease or STDs, and those with abnormal pelvic examination or investigations. Similarly for men, previous or current genital pathology, previous urogenital surgery, significant varicoceles, or abnormal examination or semen analysis. So what would we sort of be expecting is probably bread and butter for you guys from a GP management point of view, day in, day out, regardless of fertility, is so things that we can change. So advice on their lifestyle factors, exercise, diet, smoking cessation, advice on the timing of intercourse, commencing them on preconceptual folate, checking if any of their vaccinations need to be updated, of course with MMR being a live vaccine, waiting 6 weeks prior to conception, and ordering their baseline investigations. So what happens next? So initially, after they've had their consultation and testing with you, they'll be referred on to either see us in the public or the private system. We will order further investigations as required. we'll have a conversation with them, the suitability for them to have ART and discussion regarding their options. So options that we look are fitting the medical, surgical and assisted reproductive technology techniques. Medically, options are more targeted to women that are anovulatory. So ovulation induction with either letrozole, Clomid or follicle stimulating hormone injections. Consideration of metformin in women with polycystic ovarian syndrome. Targeting their weight management. Often these women may require a short cessation of their period of trying to conceive to allow for weight loss medication. Surgically addressing the problem that is needing to be addressed, so whether or not it's hysteroscopically, where they've got their polyps, fibroids, septums, previous scarring with Asherman's, laparoscopies, excision of endometriosis, restoration of normal anatomy, consideration for bariatric surgery in some of our larger women, and also male factor, whether or not urology will be involved from a varicocele perspective, or testicular sperm aspiration or extraction, and that can be done by the majority of us fertility specialists, either fine needle or an open procedure. And in terms of the assisted reproductive technology that's available, you'll all be aware of the use of intrauterine insemination for donor or partner sperm, IVF with ICSI, so ICSI is intracytoplasmic sperm injection, which is our best method for male factor infertility, the role of donor gametes and of surrogacy. So I guess my take-home messages for fertility is to take a thorough history. Age is the best marker of egg quality. Definitely have those discussions with the women over the age of 35. Opportunistic vaccination if they are known to have reduced immunity, and of course refer if unsure. So now I'm just going to touch a little bit on our public fertility service, which I'm hoping the majority of you are aware of, or if not are now aware of. So we at Northern Health work in partnership with the Royal Women's Hospital to service all the women of the North from a reproductive technology situation. So all referrals are required to go centrally through the women's, and then they come to us. You may be well aware of this referral form, but we've had it confirmed from the women's today. They're more than happy just to have a letter on letterhead. You don't have to fill in their form. It's more about the investigations that are required prior to that referral. And a list of those is provided on their website, and I've also got that here. So it's mainly regarding antenatal serology for the woman, hormone profile, pelvic ultrasound, semen analysis for the male, and also the male infection screening bloods. So referral from you gets triaged to the women's. The patient and referring doctor are notified. Then the patient's added to the wait list. That referral comes to us at the Northern, and currently patients are being seen reasonably quickly. Once they come to us, they may require 2 or 3 further outpatient appointments to do further investigation, discuss treatment options with them prior to starting fertility treatment. So all fertility treatments are accessible to public patients, but they must be provided prior to their 43rd birthday. So we run ovulation induction cycles with both oral agents and follicle stimulating hormone injections, IUI with partner sperm and donor sperm, which there is current waitlist for, IVF with partner and donor sperm, medical egg freezing. We don't provide social egg freezing through the public fertility system. And we also can only offer pre-implantation genetic testing for known monogenic chromosomal conditions, not for aneuploidy. So people that are accessing the public fertility service are entitled to 2 IVF cycles and the subsequent transfers of all frozen embryos created through these cycles. So one key point, which I think is really useful for you, is that they're unable to commence cycles within public fertility if they're transferring from a private clinic, if they have embryos in storage. So they must utilise all previously created embryos prior to starting cycles within the public fertility service. And there's an expectation that a fresh embryo transfer will occur within the stimulation cycle unless there's a risk of ovarian hyperstimulation or other medical concern. Just a touch on the donor egg and sperm bank. So it's still in the establishment phase and it's likely another 12 to 18 months from commencing. But there is a waitlist occurring at all partner sites, which is held centrally at the Women's. There have been recruitment campaigns through the Women's to establish separate unknown donor egg and donor sperm banks. And women are able to proceed currently with their own known donors after completing counselling requirements and quarantine periods for infectious screening. Where are we? So currently we are at 230 Cooper Street in Epping, where we have fertility specialists and gynecologists. We have fertility nurse consultations and medication collection, ultrasounds, blood tests, and management decisions until the time of trigger are all occurring on site at 230 Cooper Street. Once they're ready to have their trigger, all the procedural aspects are undertaken at the Women's. So egg pickup, semen collection, and all the lab aspects all occur at the Women's. Just to touch on medical egg freeze. So who's eligible for a medical egg freeze? Medicare haven't really got a set list of what consensus is for medical infertility, and a lot of it is clinician discretion. So through the public fertility, the accepted indications are prior to cancer treatment or medications that will alter fertility, trans men prior to transitioning, those at risk of premature ovarian insufficiency with either family history, Fragile X or Turner syndrome. And then there's more generally accepted. So those are women with endometriosis with known low ovarian reserve. So those with stage 4 with an AMH less than the 10th centile for their age. Gene mutations with planned IVF in the future, e.g. BRCA mutations. And also those women with borderline ovarian tumours or complex endometrial hyperplasia, so conditions that are going to delay these women's ability to conceive. And that's me for tonight. So thank you.
Great. Thanks for that, Lauren. That was very helpful. We've got a question from the audience. Lucy asks, is AMH lowering those on progesterone-only contraceptives?
No, it's usually only reduced in combined oral contraceptive. So progesterone alone is not necessarily intending to stop ovulation.
Yeah. Okay, cool. Great. I don't think there are any other questions, but definitely found that very helpful and might be ordering a few AMHs to screen some women and got a good explanation of things. So thank you, Lauren.
Okay. Thanks, everyone.
No worries. Our next speaker is Dr. Alison Bryant-Smith on endometriosis. Okay, let's just see if she's around. Dr. Alison, do you have your slides? Do you want to load them up or do you want me to do it? Oh, she's sharing. I can see them now. But you're still muted, so I can't hear you. Oh, there you go.
Great.
Cool.
Hopefully you can hear me now.
Yeah.
Beautiful. Well, thanks, Richard, for having us all tonight. As was described earlier, my name is Alison, one of the gynecologists at the Northern. And thank you to Lauren Saunders for the great primer on fertility. And Saunders, not Sanders. So bear with me. Here we go. Beautiful. So I'm going to do a bit of a primer on endometriosis. It's going to run through causes, risk factors, symptoms, signs, investigations. Going to divert a little bit the role of what's called a DIE scan, which I'll describe, and also MRI, medical management, some suggestions about when you could consider as a GP referring a patient to your local gynecology team, and surgical management. So the definition of endometriosis is the presence of endometrial glands and stroma, which normally should be lining the inside of the uterus, outside the uterine cavity. It's a really common and yet very quite often underdiagnosed condition. Incidence is thought to be about 10% of reproductive age women, but it's really difficult to confirm this. You know, we don't go around doing keyhole laparoscopies on all women just to find out the incidence. Endo is found in about 50% of women with subfertility, which Lauren alluded to earlier. Endo can cause significant morbidity from adolescence to menopause and even beyond. The most commonly held theory about the cause of endometriosis is what's called retrograde menstruation. So essentially, when any woman has a period, it's the lining of the uterus shedding through the cervix and vagina, leads to vaginal bleeding. And in some women, for some reason, we don't quite know why, it goes the wrong way upstream, up through the fallopian tubes. And essentially, women end up with deposits of old menstrual blood in amongst their pelvic organs. And that's what endometriosis is. So that's a really good theory to explain endometriosis within the abdominal and pelvic cavity, but it doesn't explain how endo can be found in other body cavities, such as pleural, around the lungs. So there's various theories floating around about that might explain the very rare circumstances of endometriosis in the pleural cavity, including lymphatic dissemination, spread cell of endometrium-derived stem cells. It's all pretty theoretical. I think for our intents and purposes tonight, retrograde menstruation will be enough. Risk factors for endometriosis. So essentially anything that increases your menstrual load as a woman. And sorry, I should have said a caveat earlier. When I refer to woman, I mean any person who was assigned female at birth. Just as Lauren alluded to, trans men who might have fertility issues, people who are transitioning from female to male can often also have endometriosis. So in terms of the term menstrual load, so those risk factors include having early menarche, so starting to have your periods early, not having had children, so essentially having had more menstrual cycles in your life, having a shorter cycle, again, more menstrual cycles, late menopause and heavy menstrual bleeding. And that really all fits with that theory of retrograde menstruation, that the more often you're going through that process of shedding the lining of the uterus and the heavier that shedding is, the more likely you are to have endometriosis. There's also a family history, so it's always interesting to ask patients if their mothers or aunties or older sisters are known to have endometriosis. There's no one gene that causes endo, but we know that there is a familial preponderance. Any Müllerian anomalies from an embryological point of view that might obstruct the outflow of menstrual blood. So for example, an imperforate hymen, the menstrual blood has nowhere to go but backwards up through the fallopian tubes. So there's a known correlation there with endometriosis. And of note, another risk factor is logically an absence of protective factors, such as hormonal suppression, which I'll define later. Mechanisms of pain in endo is much debated. Essentially, those deposits of old menstrual blood or endometriotic nodules release inflammatory mediators, which can then cause adhesions or internal scarring in amongst pelvic organs and distort anatomy. Those inflammatory mediators can also lead to peripheral sensitization of pelvic organs and viscera, and both of these processes can lead to pelvic pain. In addition, there's often an element of both somatic and central sensitization, which is where we start to think about multidisciplinary management with our pelvic physiotherapy and indeed pain specialist colleagues. The staging for endometriosis, which is you can see here in this table, is based on what's called the Revised American Society of Reproductive Medicine staging. Essentially, it's stage 1, 2, 3, and 4, which correlates with minimal, mild, moderate, and severe endometriosis. It's not a perfect staging system by any stretch. It doesn't predict symptomatic severity. So we quite often see patients who, by this staging system, have minimal or stage 1 endo, but debilitating severe pelvic pain and period pain. And it also doesn't guide prognosis. So it's not amazing. It essentially just makes sure that us as gynecologists are speaking the same language when we talk to each other. And this is some diagrams essentially that represent stage 1 through to stage 4 endo. The peak diagnosis or age of diagnosis for endometriosis is between 25 and 35 years old. And it can take, one recent study showed up to 12 years to actually be diagnosed with endo. And so I think that's where GPs play a really vital role, is trying to lessen that time for patients to actually be diagnosed and hopefully managed their endometriosis. So I found a recent article in I think it was the Australian Journal of GP, which I'll reference at the end, which suggested that endometriosis should be considered in any menstruating person with any of the following, and this is quite an exhaustive list: dysmenorrhea, so period pain; persistent pelvic pain that lasts more than 6 months, and often in the setting of endometriosis is non-cyclical, so occurs between periods; cyclical gastrointestinal symptoms, in particular pain with defecation during menses, cyclical urinary symptoms, so hematuria during menses, dyspareunia or pain with penetrative sex, and subfertility. So according to this article on RACGP guidelines, endometriosis should be considered in any patients who present with any of these symptoms. And any of those patients could potentially be, I don't want to say labelled, but could be considered to have possible or suspected endometriosis. Prompt diagnosis and treatment is really vital. Like I've said, the average age duration between the onset of symptoms and diagnosis is 7 to 12 years. And those delays in treatment can really significantly affect quality of life and disease progression. So please, if you take nothing else away from today, please organise a transvaginal ultrasound for any of those women with the symptoms that I've listed there. Some signs of endometriosis, so pretty uncommon. One that you occasionally see if you keep an eye out for it is what's called the hot water bottle sign, which you can see a photo of in the top left. Essentially, that's when a patient's abdomen becomes really discoloured just from long-term use of an extremely hot water bottle in an attempt to help with their pelvic pain. You do occasionally see that even in theatre. Very rarely, so that picture on the bottom right, you can see is a blue nodule of endometriosis, which is visible at speculum examination. I've only seen it a few times, but it's also always worth looking for. Bimanual examination really has quite low sensitivity, and a normal exam doesn't exclude endometriosis. Some signs of more moderate or severe endometriosis would be if the uterus is retroverted or flopping backwards towards a patient's buttocks rather than towards her belly button. If the uterus is what's called fixed, which means it's not flopping freely, gliding nicely amongst the other pelvic organs, it's suggestive of severe internal scarring and endometriosis. If there's large palpable endometriomas or endometriotic ovarian cysts in the ovaries, or if there's palpable nodules on the uterosacral ligaments. But like I've said, signs of endometriosis are pretty rare and bimanual exam is low sensitivity. So I think for our intents and purposes tonight, a transvaginal ultrasound is probably more helpful. So the diagnosis of endometriosis, we used to say that keyhole surgery was the gold standard. That's no longer the case. So essentially keyhole surgery is only needed if imaging like an ultrasound is negative, so doesn't show any endo, but patient symptoms persist, or if there's moderate or severe endometriosis on imaging, keyhole surgery or laparoscopy is warranted for treatment. So empiric treatment of possible endo, this is bread and butter, I'm sure. So over-the-counter pain relief, Panadol, NSAIDs, in particular naproxenic, and then moving on to hormonal suppression. So combined oral contraceptive pill, there's really no one preparation is superior to another. Some studies have shown that Gynaecology containing pills such as Valette or Clara might be superior, but it's really hard because there's not enough head-to-head studies in this area, or indeed of the pill generally. Progesterone-only contraception that could be considered. So the progesterone-only pill like Slinda, Depo-Provera, Implanon, or Mirena, which I think is our favourite as a gynaecologist. And the aim really with these progesterone-only contraceptions is to induce atrophy of the endometriotic lesions and to reduce that menstrual load that I was talking about earlier. There's also progesterone-only non-contraceptions, so Vazan, which is oral Dianogest, Primulute, or Provera, which can help somewhat with endometriosis symptoms, but aren't contraception. So essentially, the combined pill or progesterone-only formulation should be offered to all people with suspected, confirmed, or recurrent endo. And if this helps with their symptoms and they have enough symptomatic relief, there's no need for any additional management. If, however, patient has ongoing symptoms despite over-the-counter analgesia and hormonal suppression, please consider referring your patient to your local gynaecology team for further management. So non-pharmacological empiric treatment for which there's really no high-quality evidence. There's some really good apps around for education and awareness. Probably the best one that I'm aware of is what's called QEndo. which is by the Queensland Endometriosis Society, and it's fantastic. So if patients are looking for an app, I'd point them in that direction. Complementary therapies like acupuncture and Chinese herbal medicine can be good in terms of giving patients a sense of control, but again, there's no high quality evidence. I suppose it's not going to do any harm as long as they're happy to also follow evidence-based care at the same time. There is really good evidence, or at least, well, I would say anecdotal, for pelvic physiotherapy when it comes to non-pharmacological management of endometriosis, in particular for patients who have concurrent pelvic floor dysfunction, so their pelvic floor muscle dysfunction. And other symptoms of that may include dyspareunia, so pain with sex, vulvodynia, or vaginismus. So in that case, I would strongly recommend that the patients are referred to a pelvic physiotherapist, either privately or publicly through a hospital such as the Northern. So investigations for possible endometriosis are warranted if a patient's symptoms persist despite basic medical management, such as over-the-counter analgesia and hormonal suppression, and or if you've requested a transvaginal ultrasound and it's suggested moderate or severe endo. So if either of those are the case, persistent symptoms or a basic scan showing moderate or severe endo, please refer the patient to your local gynaecology team. What do we do? So if a patient has mild endometriosis, so either no or mild endometriosis on a basic ultrasound, but they have persistent symptoms and referred to us as a gynaecology team, we'll make sure that we optimise their medical and allied health management. And I'll talk through each of these next 3 points. First off, the GnRH agonists. So which includes Zoladex, which is a monthly goserelin injection, which you may well be asked to administer to your patients, or Cinerel, which is a BD nafarelin nasal spray that patients can do themselves. The aim of these medications essentially is to induce medical or temporary medical menopause. So it turns off the ovaries, a woman's estrogen levels plummet, and any estrogen-dependent process like endometriosis should be suppressed. So in the setting of a patient who has significant symptoms but no or mild endometriosis suspected on ultrasound, to some extent we can use these medications as a diagnostic test. If they try a few months of either Zoladex or Cinerel and their symptoms improve, it really strengthens the case for keyhole surgery to look for and excise any of that mild endometriosis. If, on the other hand, they try a few months of Zoladex or Cinerel, there's no symptomatic improvement, then to some extent there's less benefit to be gained from keyhole surgery. So we would probably prefer that they try multidisciplinary management, such as that provided by a pain specialist, pelvic physio, a psychologist, etc. We've got a persistent pain clinic at the Northern who really bring together all of the experts for these kind of patients. Of note, with the GnRH agonists, the use is limited to a 6-month course, given the impact on bone mineral density, so can lead to irreversible osteoporosis. Moving on from GnRH agonists to GnRH antagonists. So this is a new medication on the market. It's only been licensed over the last year or so. I'm not quite sure who thought of the name, but it's pronounced Ryeqo, the reps tell me. Essentially, it's a once daily pill, which is a polypill of 3 different medicines, relugolix, estradiol, and norethistramine. And the way it works, so the relugolix essentially induces the same temporary and reversible menopause that GnRH agonists do. The estradiol adds back just a smidge of estrogen to help with the hot flushes that are caused by the relugolix. And then the norethistramine is the progesterone, so that we're not giving unopposed estrogen and leading to possible high risk of endometrial hyperplasia. So it's quite an exciting new medicine. One good point is that it can be used indefinitely until menopause. There's not that same 6-month course limit. A definite downside, and I think a really prohibitive rate limiting step, is that it's $135 out of pocket per month, which is really prohibitive for the vast majority of patients, certainly that we see publicly. And at the moment, the drug companies are saying that patients need to have an annual DEXA scan, which again isn't covered by Medicare, and so would need to be out of pocket. So again, quite prohibitive. So that's probably There's developing studies in Europe and America, so it's a bit of a watch this space, and we'll see whether or not that ever gets PBS backing and subsidisation. The next step we would often consider is laparoscopy, plus minus excision of endometriosis, and then also consider insertion of Mirena for ongoing hormonal suppression if the patient doesn't want to conceive in the near future. And the surgery really here aims to remove visible endometriotic nodules and normalise distorted anatomy. Has been shown to improve most health-related quality of life domains. The evidence for fertility is limited. The best we can say is that it might improve fertility outcomes for patients with stage 1 or 2, so minimal or mild endometriosis. However, needs to be said, surgery is not curative. So about 40% of women experience a relapse in symptoms. And in terms of post-op hormonal suppression, such as Mirena or the pill, this post-op hormonal suppression might provide secondary prevention of pain and may prevent disease recurrence. But that's about as strong as we can say based on the current evidence. I think we always tend to encourage patients to consider a Mirena in this setting, the rationale being, again, reducing their menstrual load. Anything that lightens their periods and decreases the frequency of their periods is, biological plausibility, likely to slow the regrowth of their endo. But that's about the best we can say. So that's essentially what we as gynecologists do to consider the management of mild endometriosis. Moving on now to moderate and severe when this is suspected on a basic transvaginal ultrasound. So again, we would consider potentially a role for GnRH agonists. This is a slightly different context in that we suspect on the basic ultrasound that a patient has moderate or severe endo. So for example, the basic ultrasound might show bilateral big endometriotic ovarian cysts, a fixed uterus, suggestive lots of internal scarring, all the internal organs stuck together, which are all red flags for severe endo. If the patient's open and it's safe to prescribe a few months of GnRH agonists, such as Zoladex or Cinerel, it might provide them some symptomatic relief, which buys us a few months to plan a combined operation, which may need to involve the colorectal surgeons or the urologists. And really the rationale here for trying the GnRH agonists is to shrink the endometriotic nodules and then provide symptomatic relief to the patient. And again, just buys us a bit of time to plan their operation. Further imaging is warranted if we've got a basic transvaginal ultrasound showing possible moderate or severe endo. And so I'll now just spend a little bit of time talking through what's called a DIE scan or an MRI. So DIE stands for deeply infiltrated endometriosis and essentially is moderate or severe endometriosis. Just over the last year or so, I think we're all pretty excited to be able to offer these DIE ultrasounds at the Northern. We've got a fantastic gynecologist as part of our team, another Alison Chung, who essentially is dual trained in both ultrasound and endometriosis surgery. So she's a real boon to have as part of our team doing these ultrasounds. If patients need to go privately, they need to pay about $260 out of pocket. And these ultrasounds aren't done by everybody. So you need to really seek out a specialist women's ultrasound service. So for example, specialist imaging for women in Heidelberg, women's ultrasound specialists in Fitzroy, just can't send them to your bog standard sort of capital radiology, FMIG. Really need a specialist women's ultrasound company to do these scans. The DIE ultrasounds provide a lot more detailed information, and they really, for us as surgeons, paint a picture of exactly where the endometriotic nodules are, how big they are, which organs are stuck together, how big the ovarian cysts are, and they really paint a picture that allow us to plan a patient's keyhole surgery. They give us a sense as to whether the pouch of Douglas, which is the potential space between the cervix at the front and the bowel at the back, is open as it should be normally, or whether it's completely stuck together with internal scarring, what's described as being obliterated. They can also clarify whether or not there's any nodules on the bowel and even the depth of that bowel nodule. So whether it goes entirely through the depth of the bowel walls, the mucosa, or whether it's more superficial. And again, that will guide the colorectal surgeons as to what their involvement might entail. A good DIE ultrasound is as sensitive and as specific as an MRI for that deep, severe endometriosis, and it's becoming better year by year. MRI is unfortunately not only subsidised by Medicare for the purpose of surgical planning if the patient has already had an ultrasound suggestive of DIE. So given DIE and MRI are really on par in terms of sensitivity, for us, I think we find really the role of MRI is for women who, for whatever reason, don't want or can't have an internal, so transvaginal ultrasound. So in addition to further imaging, gynaecological management of moderate or severe endo often includes a multidisciplinary approach, including the colorectal surgeons and the urologists as needed, depending on where the endometriotic nodules are, fertility teams such as Lauren's, and a pain specialist. Surgical management can include any of laparoscopic, so keyhole surgery, excision of endometriosis, adhesiolysis or separating that internal scarring, removing the endometriomas or the ovarian cysts, checking a patient's fallopian tubes to see whether they're patent or not, potentially removing the fallopian tubes if their family is complete. And again, that's considering the idea of both possible risk reduction of future ovarian cancer, but also reducing that process of retrograde menstruation. And then colorectal or urological involvement as needed. The data for fertility improvement following surgical excision of stage 4 endo is less clear. We do need to acknowledge, as Lauren has alluded to, that we need to be careful about the judicious use of ovarian cystectomy, given its impact on ovarian reserve. We very occasionally think about offering a hysterectomy, so surgical removal of the uterus, and indications for that include, obviously, if the patient's family is complete, if medical or surgical interventions have been ineffective, or if there's concurrent heavy menstrual bleeding and or adenomyosis, which would strengthen the argument for hysterectomy. But we also need to acknowledge that pain symptoms can persist or recur even after hysterectomy. Post-operative management, so really depends on the patient's findings at laparoscopy, so the severity of their endometriosis, and if they've had any symptomatic response or lack thereof to that surgery. So the patient will have either had negative laparoscopy, so no endometriosis found at all. Hopefully they will have had complete excision of their endometriosis, but very occasionally may have incomplete excision. And then following that keyhole surgery, they will either have good symptomatic response with good symptomatic improvement or potentially persistent symptoms. And so ongoing management post-op is really guided by the findings at their keyhole surgery. Was there any endometriosis? Yes, no. If there was it completely excised or not? And then whether they have ongoing symptoms or not. If the patient's had a good symptomatic response to their keyhole surgery, we'd consider ongoing hormonal suppression, such as the Mirena, combined oral contraceptive pill, or progesterone-only options, which I've run through earlier, between pregnancies. And if that management is working well, there's really no need for regular gynaecology review. We only need to see them if they have recurrent symptoms. And so gone are the days of the annual keyhole surgery. If patient has persistent symptoms following their keyhole surgery, and that's despite either negative laparoscopy or complete excision, we would hopefully impress upon them the possible benefits of ongoing hormonal suppression. But we also need to think about involving pain specialists, pelvic physios, dietitians, and psychologists. And that's really where that multidisciplinary team, such as the persistent pain clinic, really comes into its own. If a patient's had incomplete excision and they have ongoing symptoms, again, need to emphasise the importance of hormonal suppression. Think about a possible role of GnRH agonists or antagonists, possible referral to a more experienced gynecological surgeon, or occasionally this can happen, a patient may have a bowel nodule that they choose not to excise at their first keyhole surgery. If they have ongoing bowel symptoms, they may choose to have more aggressive excision by the colorectal team in future. This is the article that I was referring to earlier. And in this article, they list some really good resources. The top one you can see is the Q-Endo app, which I often recommend to patients because I think it's great. So take-home messages. So symptoms suggestive of possible endo include the ones I've listed there. Consider a short trial of Panadol and NSAIDs. and a 6-month try of hormonal suppression to manage any of those symptoms, except obviously subfertility. The pill's not going to help them there. And then if the patient has ongoing symptoms despite empiric analgesia and hormonal suppression, if you can please organise a transvaginal ultrasound and refer the patient to your local gynaecology team, we'd appreciate it. We, as the local gynae team, may think about the place for GnRH agonists or antagonists, a DIE ultrasound or an MRI, and laparoscopic excision, which can involve our colorectal and urology colleagues. Persistent pelvic pain following complete excision is really challenging and often involves multidisciplinary teams, some of whom I've listed there. Beautiful. Thanks very much.
Thank you for that, Alison. That was a wonderful talk and very relevant. Thank you for mentioning some of the guidelines and how some of the new drugs work. I've got a couple of questions. So I guess one of them is, how good is a standard ultrasound at capital alignment for an initial investigation? How hard should we be pushing for like a DIE scan?
That's a really good question. And like the answer to most good questions is it depends. It's a huge spectrum. We still occasionally, unfortunately, as GPs, I'm sure know, get ultrasounds that literally say she has a uterus. Not particularly helpful. The other end of the spectrum is sonologists who really go above and beyond. They know what they're looking for and they describe it beautifully. So it's very variable. I think if you're not happy with one provider, try another. And I think if the patient has capacity to pay for a specialist ultrasound, it's easy for me to say because it's not my money, but I think it's money well spent because essentially it paints just a beautiful picture for us as surgeons that we can know exactly what to expect and exactly how to plan the best operation for the patient.
Okay, great. Yeah. And then
I should say as well, so Jo Vivian Taylor, feel free to jump in if you've got anything to add to these, because I know that you love some endo as well.
Perfect. We'll see if she has anything to add. And the second question is probably something that GPs probably see a lot because it can be hard to get into a gynecologist last minute. But how do we manage flares? So known endometriosis, often something I'll see in the virtual ED space. They come in and they're just having like a bit of a crisis. And I know there's a bit of a pushback against just ordering another pelvic ultrasound because I think these women get scanned really frequently, and they say that more scans are probably not going to add more value. But is there anything that you could say works really well, or what would you say about that?
Gosh, yeah, great question. Hard to answer. So I suppose you want to make sure that you've done all the basic things so that they have, maxed out the Panadol and the anti-inflammatories. Quite often, I mean, once we get our pain specialist team involved, they start talking about gabapentin and medications like that. That's probably not something you want to be starting, in the acute setting. You could, reconsider hormonal suppression, but again, that's going to take a while. So there's no easy acute options there. Jo, do you have anything you want to add to that? Sorry to put you in it a little bit.
No, not at all. I think, Richard, the thing is, you raise a really important point that women are presenting in crisis because the system isn't really doing a good enough job beforehand. And I'm hoping that with the women's health clinics across Victoria, which I'll speak a little bit later, and with these sort of webinars, I guess the aim is that we get women to the point where they don't present in crisis because they're scared that suppresses their hormones. So many women who come into ED and get admitted under us are not adequately suppressed or haven't been to a persistent pain clinic, multidisciplinary pain clinic, and not linked in. So I don't have any answers for the acute setting, but I definitely think that it's hopefully we're moving towards minimising those presentations, I suppose, with a better multidisciplinary and interdisciplinary space, I suppose.
Yeah. And I guess
Thanks,
this
Jo.
is a good, and thank you for that, Jo. And I guess this is a really good segue into one final question, which I have is just probably a common GP presentation. So painful dysmenorrhea, intermenstrual pain, suspected endometriosis, has had scans and a workup, and she's heard about endometriosis, this patient. So they often ask you, and they often already tell you they've got endo, although you check her notes and there's nothing confirmed. She wants a referral to the gynecologist, and that the Northern's waiting list is going to be 12 months without proper diagnosis anywhere. Like, this is still undifferentiated pelvic pain. I guess the question would be, now I know about the DIE scan, that's an avenue, but would you say refer first, Richard? Or, it'd be great if you got some, it'd be great if there was another avenue for her. What would you say? Sorry, I know that's a
Sure.
real,
No,
really
good question.
questions, but these things
Good
come
question.
up.
Yeah. So look, I think a patient like that, if they've had a basic transvaginal ultrasound, and it hasn't shown any red flags, like there's no big endometriotic cysts, the uterus is mobile, the ovaries are mobile, like all the organs are slipping and sliding nicely, a basic ultrasound will be able to diagnose moderate or severe endo. So by definition, if they've got a normal, good quality transvaginal ultrasound, not one that just says she has a uterus, we can say that they have possible minimal or mild endo, but can still have really significant, debilitating period pain and indeed sort of ovulation pain, despite only surgically having minimal or mild endo. Definitely refer, and if you need to, I know it doubles your workload, but write another referral trying to impress upon the severity of symptoms and the need for urgent review. If they've got adequate hormonal suppression, and they're doing all the regular routine over-the-counter analgesia, you're doing everything we could ask of you. If they've got a normal basic transvaginal scan, I don't think there's a lot to be gained from doing a DIE ultrasound. I think really the role for those DIE scans is when you've got a suspicion on a basic ultrasound of moderate or severe endo. So, those big ovarian cysts that are thought to be endometrioma cysts. And another giveaway is cyclical bowel symptoms. So if they describe that they've got normal bowel habit most of the month, constipation before their period, and then diarrhea with their period, and they get that cyclical monthly pattern every single time they have their period, that's a bit of a red flag for possible bowel endo, which I think would warrant a DIE scan. Jo, did you want to comment there? Or?
Yeah, I guess I would just sort of add, and Richard, obviously you've been a member of our team, so perhaps not the audience, but I guess we see a lot of people referred who haven't been suppressed. I guess that would, for me, be something I'd like to encourage our GP colleagues to be confident to suppress women whatever way they can while they wait on that terrible wait list that is my job to fix. Because the reality is, if they are waiting, and I think it's hard, I imagine it might be hard for GPs, because I hear it sometimes in the patients that they maybe think that the GP's fobbing them off by suppressing them, when actually you guys know they're going to be waiting a long time to see us, and suppression is part of the treatment. And so maybe spending that time to really explain that, yes, you could well have endometriosis, and in fact I suspect that, but part of the treatment is the pill, Depo, Mirena, all that kind of stuff. And, I'm not fobbing you off, I'm referring you, but I'm also or I'm not referring you, I'm actually starting the treatment, because I do see a lot of women and I'm a generalist, not a, like a high level endometriosis. So I do see women in clinic where I seem to have those conversations, whereas I think if those conversations are pulled back to general practice and initiated, then I think women will get better pain control and hopefully turn up to emergency less and things like that. And I think the other thing that we're really, many of you will know that there's currently a Senate inquiry into women's pain at the moment, and that's not just about gynecological pain, but obviously gynecological pain and endometriosis related pain is a big part of that. And I think the fact that we've got that Senate inquiry going at the moment is just really a symptom of women not feeling listened to. And I think that all of us, us gynecologists and also our GP colleagues, really have to do a lot of self-reflection at the moment and look at the way we kind of communicate that stuff to our patients, because there's nothing more powerful, I suppose, than saying, yeah, I do think you probably have endo. I know your pain is real. I had a patient almost burst into tears today because she's had terrible, heavy and painful periods for many years. And I said, oh yeah, we could use a marina for that. And she said, I can't believe there's actually an answer. I'm thinking, I think it's a really simple answer.
Yeah.
And
Yeah.
so I just think we should, we all need to kind of listen to women's pain, believe women's pain, and start some suppression rather than just waiting for the gynecologist, especially in the public sector, which it's not good enough. I wish it was not the way it is, and hopefully we'll be able to fix some of it in the coming years. But yeah, I think if we can be part of the solution for those patients, that'd be good.
Yeah, that's great. And I think the pressing upon how important suppression is, I think it's something that GPs let patients get away with because they're often like, oh no, my friend had a bad experience, I don't want the implant on. And I get that probably half the time. They've never tried these hormonal treatments and, you don't know how hard to push, but now with the support of having done this talk, I think it'd be really good to spread that word. So thank you, Alison. I don't know if you want to add anything.
Alison, and possibly Lauren. I don't think that Implanon suppresses enough for endometriosis. The depot was kind of there, and it's amazing at suppressing, but it's obviously rotten in terms of side effects for some women, not everybody. And then in response to that, I feel like Implanon and obviously the Marina came out from a contraceptive alternative. I would never use it for endo, but am I doing analysis in that statement or
No, I agree, Jo. Yeah.
Yeah, great. That's a really good learning point too. And and on the Senate inquiry, there's a really big women's health symposium going on this Thursday, which I'm going to, so that'll be really interesting.
Yeah.
Perfect. Thank you, Alison. So Jo, I'll hand the floor to you on an update on the cervical cancer prevention and cervical screening. Thank you.
Thanks, Richard. And thanks to Alison and Lauren for taking the time to come out tonight. I appreciate it. It's an exciting time to be part of our team at the Northern. When I started there 10 years ago, I was the second female gynecologist there. And as you can see, I'm under 60 still. So yeah, it's a really exciting time. Lots of female gynecologists. Alison and her endometriosis team are able to do all levels of endometriosis surgery at the Northern, which we couldn't do up until quite recently. So it is really exciting. I'm just going to share my screen. And
yeah, I can see your screen now. That's working.
Sorry. So I'm just apart from being head of unit at Northern, I'm also my special interest area is colposcopy. So as many of you know, there's been quite a few changes over the last few years and continues to be in the guidelines and I suppose in this space. So I just thought I'd provide a bit of an update and then some comments about the women's health clinics that I alluded to before at the end. So as many of you may know, there's a current, the WHO has a current strategy to eliminate cervix cancer worldwide. And obviously worldwide cervix cancer is a much bigger problem than in Australia. But the aim is to get to 4 or less cases per 100,000 women, of which Australia is not there yet. And the WHO strategy aims for 90% of girls fully vaccinated, 70% screened and that's not regularly screened like what we have, but screened by 35 to 45, and then 90% getting appropriate treatment for dysplasia, but also cancer. In 2020, Australia had 80% of girls were fully vaccinated by age 15, but obviously that excludes people who migrated to Australia after their schooling. And working at Northern Health, this is a big part of what we see, particularly with HPV 16 and 18. We had 62% of women aged 25 to 74 participating in cervical screening regularly, or regularly enough. I mean, it's a pretty loose definition of regularly, so it's not great rates of participation. And almost 90% are getting their treatment in the timely fashion. And the incidence of cervix cancer in Australia is 6.5 per 100,000 women. So then, in response to the WHO, Australian strategic targets towards the elimination of cervix cancer is 90% of eligible people will be vaccinated against HPV. And they say eligible people because there is some opportunities for catch-up programs outside of just the school-based group. That 70% of eligible people will be screened every 5 years. So that's regular screening rather than just once or twice in their lifetime. And that 95% will receive optimal treatment for pre-cancer and cancer in a timely fashion. I think that's within 6 months for dysplasia. So when we think about cervical cancer prevention, we know that communities that speak English as a second language and lower socioeconomic communities do have lower rates of cervical screening, and sadly subsequent also high rates of cervix cancer. And Northern Health is in an area with high rates of people born overseas and of particular note schooled overseas. So missing out on that, the vaccinations in schooling. And really, once you've started, the reason that we don't, have a catch-up program for these people is often they have started sexual activity already before they've come to Australia, and so the effects of vaccination goes down. So some of the strategies in the Australian setting to reduce cervix cancer in priority populations have been about improving our screening rates. So opportunistic screening, self-collection for all, as you know, has moved recently changed so that it used to be self-collection for people who are under-screened or never screened, but now self-collection for all because the sensitivity is the same as for a clinician collected sample, and obviously expanding the people who can take a clinician collected sample to include nurses and other healthcare workers who are trained. There's also a catch-up vaccination, which you guys would know more about in general practice, I'm sure, but just to remind us that there is a catch-up vaccination available to these priority populations. And so we do need to continue to try and get people vaccinated because at the end of the day, that is what will prevent all of these problems. And obviously we have Nova vaccination to cover more subtypes. So cervical screening guidelines, just a few points. So primary HPV is the screening is primary HPV testing every 5 years, and this is more sensitive for the detection of HSIL than cytology alone every 2 years. And these are the sorts of things that come up hopefully less commonly with patients now, but certainly did when it first changed, but it still does come up in why we're doing it every 5 years rather than 2 years. Cervical screening is with primary HPV and a reflex cytology if the high-risk HPV is detected. And this leads to lower rates of cervix, predicted to lead to lower rates of cervix cancer than 2-yearly cytology. So we're getting better coverage. And one of the big areas that will help, it helps in is the area of adenocarcinoma, where the 2-yearly cytology made absolutely no difference really to the rates of adenocarcinoma, whereas primary HPV testing does. And just a reminder that cervical screening is a screening test. It's not a diagnostic test. And if someone's symptomatic, they need a diagnostic test, which is a co-test. And also, obviously, we use the co-test for post-HSIL treatment as a test of cure. And it is important to think of, to remind ourselves, I kind of have to do it often. I suppose the other place where we use it as a diagnostic test is in colposcopy. If we repeat the liquid-based cytology, that would be in the context of it, that would be considered diagnostic. And just a reminder that the guidelines changed recently so that unless women are in a high-risk population, such as outlined down there, so women over 50, women who identify as being Aboriginal or Torres Strait Islander descent, or are 2 or more years overdue for screening at the time of the initial test, they really don't need to be referred for colposcopy until they've had 3 or at least 3 tests with HPV other. So this does not apply, obviously, to HPV 16 and 18 with normal or low-grade liquid-based cytology. And this was in response to a review of the National Cervical Screening Program data that basically found that there was no increased risk of invasive cancer after if we screened after 3 years compared to 2 years. And it really came out of the pandemic, because the access to colposcopy and also the pandemic, but also the significant increase in referrals to colposcopy that came from the change to HPV based screening. And so in order to try and, prevent the system from breaking, they went back into the data and informed this change based on what they found. So a few things that I just, I guess, want to impart to you guys as the people who are seeing patients when they get their results back. Just from, my experience of seeing them in colposcopy in the state they sometimes turn up in. I guess it's really important to think about, excuse me for being so crass, but, most women basically turn up to colposcopy, regardless of what the result is, thinking that they're dirty whores, or that they're going to, and that they're going to die of cancer. So if we remember that basically that's what everyone thinks when they have an abnormal pap smear, then we do it. It's really important that we do a lot of work to dispel those myths and reassure our patients. So we need to reassure them that they don't have cancer. I say don't because obviously I know some of them will, but the vast majority won't, especially if their cytology is normal or low grade. And especially if they need to wait some months on a public wait list to see colposcopy, it's really important, obviously, that you guys can do a lot of work to reassure them and support them through that time while they wait. Anyone with a high grade LBC, that they need to be seen within 8 weeks of referral received. But if the cells are normal or low grade, then that can be pushed out for some months. Lots of reassurance around HPV itself, because obviously it is sexually transmitted, so people think they've got a sexually transmitted disease and all the implications of that, and who had sex with who, and what does that mean about me, and all this kind of stuff. So just to remind them that having HPV is a normal part of being a sexually active adult. 90% of sexually active adults will have HPV at some point, and I always just say it just depends on which one you happen to get and what your body happens to do with it. So if it clears it or retains it. Obviously smoking is associated with an increased chance of retaining HPV and persistent HPV, and therefore the development of dysplasia and ultimately cancer. But apart from that, there's really nothing else we can do. It's not genetic, and it's really important that we reassure our patients that just because their mother or auntie had dysplasia or cancer, that's not it doesn't increase their risk. Predict that patients worry about having HPV as a sexually transmitted disease. I get a lot of questions about, do I need to tell my partner and all this sort of stuff. I don't feel that it's necessary, because someone gave it to someone, and who knows who, and the male partner's probably cleared it, and I leave it up to them really about what sort of relationship they're in, rather than seen as a medical issue. And just reminding patients that the HPV status really is about alerting us to the potential for dysplasia, and the cytology, colposcopy and biopsy is about making the diagnosis. And the HPV, and obviously from our perspective about the HPV status, is about the sensitivity of the test, and then the specificity comes from those diagnostic components. And if you have, and also just to give them as much information about what to expect at colposcopy, we do have a patient information leaflet that we sent out. It's been going out a bit inconsistently lately, so we're doing some work around that now to make sure it goes out to all our patients. But we have had a few patients lately turn up thinking they're just coming for a chat, and it's really important that they understand the basics of what a colposcopy is, so that they will stay. And just a reminder, and we all need to remind ourselves of this, especially when we get a bit immersed in the treatment of dysplasia, that the cervical screening program is to prevent cancer rather than treat dysplasia, and it is a slightly different kind of concept. So I often remind my colleagues and myself, even sometimes internally, that, you know, of this when we, and also patients, I suppose, it's really, you know, when we want to sort of stand strong for our patients. So we don't treat normal and low-grade cytology, even in the presence of high-risk HPV, and the guidelines are very clear on this. And, you know, besides the fact that we would just lop off every second cervix if we did, remember that HPV can persist on the vagina. So treating women with normal or low-grade cytology not only you know, potentially puts them through unnecessary surgery. It doesn't take away their HPV, and then they end up with stenosed cervixes that are even harder to get good cytology on. So there's lots of reasons to really support women through the monitoring of these conditions, rather than you know, treatment always being helpful. Another area is in the setting of HSIL with CIN2. So CIN2 can be managed conservatively. It's in the guidelines. It does require strict criteria, and there's some you know, a good quality data to support this. And we do this often, but we really pick our patients. So the patients that are very suitable for this conservative management are the women who've sort of got some low-grade cytology or colposcopy, so they're sort of on the low-grade side of CIN2. You need to have a type 1 transformation zone, so that means that I can see all of the area and monitor it adequately. You don't want the transformation zone to be inside the os, where you just can't get a visual monitoring on it and a biopsy. And so it's really young women who haven't had children or and want to try and, you know, avoid LETs or surgery for their dysplasia prior to having children. CN3, again, obviously, you know, high grade, the words high grade don't help the situation, but just a reminder, you know, this is what I say to the patients, especially when I've got discordant results in younger women, where we want to just give the cervix the benefit of the doubt and maybe monitor them for 6 months or so before we rush into treatment. So they might have a possible high grade cytology, but low grade biopsies or something like this. And just to reassure them that, and another situation obviously is pregnancy, where we don't rush in and treat all any, you know, high grade disease. We just monitor for the evidence of invasion, and if that doesn't develop, then we will defer treatment till after pregnancy. And I remind our patients that the average time to cancer from CIN3 is 8 to 10 years, if it even develops, because as you know, some people will regress with HSIL, although we try not to take a punt on it. So just reminding them that the average time to cancer development is 8 to 10 years. So most people, it is quite safe to have a short period of observation if that's needed to make a more definite diagnosis in a younger person. And just a reminder, I suppose, of, again, we're here to prevent cancer, not treat dysplasia. These are just some, both in HPV 16 and 18, and that's all comers, obviously, regardless of cytology. And in the second group there with HPV non-16, 18 and LBC prediction of high-grade type of cytologies, the rate of invasive cancer after that is less than 1%. And so it's just a good reminder, I suppose, that the absolute vast majority of women do not have cancer, and we would see, particularly that second group with cytology of HSIL, we would see them within 6 weeks of their referral. This is just some data about on a project we did at the Northern around self-collection in pregnancy. And it sort of alludes a little bit to that opportunistic screening and self-collection. So we just thought about when they brought in self-collection for all, we decided to do a project where we promoted self-collection during pregnancy as a way to try and increase our overall cervical screening rates for patients. And as you can see, just from the data, before self-collection and compared to after self-collection, we had a good increase in the uptake of cervical screening with self-collection. However, it really just moved the underscreened into the up-to-date group. It made no inroads in the never screen. And it's just a reminder that it's the never screen population that I need you guys to help me with, because they are tricky, and they are the most at risk of cervix cancer, and they're often also the people who are under vaccinated in our country. And I think the other thing that we found was that it was reasonably, we don't know why those never screened were, we don't know whether they were offered. It was just like a project. It wasn't like a trial, if you know what I mean. So we don't have data on whether they weren't even offered screening. But in overall, the acceptance of self-collection in pregnancy was very good. And so I'd encourage your to promote self-collection for all patients really, but particularly targeting that never screened population. And just a little bit of stuff around the treatment of high-grade disease and the risk of preterm birth, because obviously that's sort of the downside of screening. You know, yay, we're preventing cancer, but you know, there's always a dark side. And it's just important that we kind of have correct information, I suppose, that you can provide to your patients, because they may well come to you guys asking these questions. So we know that the risk of preterm birth is higher in women with CIN of any kind than women who don't have CIN or that have any kind of dysplasia compared to no dysplasia, whether that's a product of the dysplasia itself or or other risk factors that are you know, that are common to preterm birth and women who have risk factors for having dysplasia. We don't know. I guess the good things are most women less than 45 or less than premenopausal, but particularly less than 45, can be treated with a shallow excision. So we'll be aiming for something equal or less than a centimetre. We're aiming for 7 millimetres, but you know, anything up to 10 millimetres is acceptable. And for women who undergo ablative techniques, so in this case in Australia, I'm talking about laser, of which really that's only available at the bigger centres that have enough cases to actually warrant having a laser. We don't have a laser. And having done laser treatment when I was at the Women's, I don't think it really adds that much, especially with newer data around depth of excision and stuff like that. So we know that risk of preterm birth is higher for cones, which is higher for which is higher risk than for LETs, and then ablation is the least, with a laser is the least risk. And we probably think this is about depth of excision rather than necessarily the technique. And the downside of a laser from our perspective as colposcopists is you don't have a piece of tissue to send to the laboratory, so that can be a risk as well. And so we think that we know that the risk of preterm birth is higher the more volume and the depth of the excision that you take. And so there's been some more recent small studies around the depth of LETs that basically found that after only, if their patients only had one LETs procedure, and there were two studies, one said at a cutoff of 1.2 and the other said 1.5, which is not what we are aiming for in this younger population in the majority, then there was no increased risk of preterm birth. But if you got over those depths, or if they needed more than one treatment, then it did increase their risk of preterm birth. And I think that's important, I guess, to reassure people that most people will not have be at increased risk of this, and we'll know that after we've taken the specimen out. But also, I suppose, if you're referring patients for obstetric care and they've had more than one LETs, it's important to include that in their referral. If you know they've had a deep LETs or a cone biopsy, it's really important that you include that in their antenatal referral so that we can provide cervical surveillance in that population. So we don't do cervical surveillance in women who've had a LETs, but we do offer cervical surveillance for women who've had more than one LETs or any kind of treatment, and a type 3 excision, which is at least 1.5 centimetres. So that's sort of the end of the update on cervical screening. Obviously, I'm happy to take questions at the end. I just wanted to also mention these women's health clinics. Some of you will have already heard that the Victorian government has is starting 20 women's health clinics across Victoria. And they're starting 5 this year, and Northern Health is part of that. The others are women at the Women's, Barwon Health, Peninsula Health, and Grampians Health. The idea is that is to provide interdisciplinary specialist women's healthcare. And so that will include a team of, gynecologists, endocrinologists in the menopause space, clinical nurses, which is new in the gynecology space, particularly outside of the big centres, and quite exciting. And then some of the clinicians that Alison was alluding to, particularly in the persistent pelvic pain, endometriosis space, but also in prolapse and incontinence. So physios, dietitians, psychology, and social workers for comorbid social situations such as domestic violence. And there will also be a role for women's health GPs in these clinics. Now, every health service can, there's sort of a broad model of care that the department has set out, and then each health department is sort of moulding that model of care according to existing services and what the local gaps are and demands. So apart from tackling my enormous wait list, we are planning to set up a few things that are new to Northern Health. So we're planning to start a complex menopause service. So that will be predominantly for women who have complex medical comorbidities that make HRT, contraindicated or, possibly contraindicated. Premature menopause and menopause after cancer will be the focus of that clinic. And a persistent pelvic pain service as well with interdisciplinary team. And we're also going to start an IUD clinic for difficult IUD insertions, and also to service some of our own internal referral processes. One of the reasons for bringing it up, apart from telling you guys that it's starting and that it's exciting opportunity to provide interdisciplinary specialist women's healthcare in the public sector when, outside of the big centres, it's not really been available for us, is that there will be roles for GPs in these clinics. And so just to kind of outline some of those roles, and obviously for anyone who might be interested in being part of it. So one of the things we're planning to do at Northern Health is to try and improve the number of GPs in our local area who feel confident to put in IUDs for contraception or other gynecological conditions. And so in order to gain that experience, there will be opportunities to rotate through the clinic. And we haven't sort of finalised whether that'll be 3 months or 6 monthly, and it would just be a fortnightly clinic for the duration of that period, just to gain that, I suppose, regular practical experience to then be able to take back out to primary care to improve access to IUDs and long-acting contraception for our patients. And there will be potentially other roles for GPs in our service, potentially in that complex menopause clinic or other women's health clinics. It's still being finalised, but I guess I just wanted to mention it, because if there's GPs who, in your group who are interested in any of that, just keep an eye out. I'll send all the job ads to Richard to circulate, or reach out to him if you want to know more particularly. But I just wanted to mention it so that we can, get people interested before we start to try and recruit or plan. So happy to take questions. Sorry, I've run over a bit.
All good. We've got one question come up from the chat, and that is from Kieran. How do we know about these clinics or participate in them? So you'll send them, but in terms of timing, do you have an idea which month they might be opening?
Yeah, great question. Really, we wanted to be starting the 1st of July, but we're way too close to that. So this second half of the year. When I say, I shouldn't say definitely, should I? I should never say definitely, but we are aiming for the second half of this year to commence.
Yeah, cool. So Kieran, you can reach out to either myself or Sandy, our primary care liaison, through the Northern Hospital, and we'll keep you in the loop, because we'll be reaching out as well. I had a quick question, Joe, and that was just about your view on the HPV vaccine for people after the age of 15. And I see this a lot in overseas, sort of immigrants here for education, particularly the Chinese as a culture that they come get vaccinated. But do you have an opinion on those who are under 45 and eligible for a vaccine if they're happy to pay for it?
I think you just put the nail on the head if they're happy to pay for it. I mean, I think that's the problem. It's really expensive. For, it's about, what's it, about $1,000 for 2 doses or something like that. And that's if you're still eligible for 2 doses. Once you get old and crumbly, like me, you have to have 3 because your immune system's shot. So it's really, it's about the cost, to be honest. I think, if you do, it's that for me, that it's enormous cost. And I think, what are we trying to prevent? If people are engaged enough to get vaccinated, are they going to be engaged enough to turn up for screening? And then you're going to prevent cancer anyway. So I don't like the idea of making people feel guilty about, if you had $1,000, then we could prevent you from getting it. I feel really strongly about that we should be providing public access for public healthcare and not making people feel ashamed. But if they can afford it and they have that money lying around, I would never discourage it. Because HPV 16 and 18 are just awful. I guess the only other thing is if they've already started having sex, then if they've already been exposed to any of them, then it doesn't help. Obviously, it's a vaccine, so it's prevention, not treatment. I guess now we also have HPV screening. So if you screen them and they're high-risk HPV negative, that's a pretty good start. So either they've not had any of them, or they've had them and they've cleared it, in which case they've got their own natural immunity anyway. So I think, I think it's a really individualized conversation, and unfortunately, it's about cost.
Yeah,
but I think there's benefit if, especially if they're young and they've got a long career ahead of them in terms of reproduction. So, we know that from HPV 16 to getting HSIL, so the average age of having first intercourse in Australia, 16, then, you get your HSIL in late 20s, early 30s, late 20s probably to 30. Then if you go untreated, then you have your cancers late 30 to 50, early 50s. That's the natural history. And so if you're, I don't know, had your children and you're 32, you're having your vaccine, you've got to think about why you're having your vaccine. You're having your vaccine to prevent you from having colposcopies annoyingly for every year. I do colposcopy, so I think that's a good reason, but it's a lot of cost in order to prevent that. Whereas if you're 20 and if you've actually never had sex with anyone, then that's a lot of benefits. So I think it's all about weighing up the individual benefits, I suppose. Yeah, that's the problem.
Yeah. That sounds really reasonable. Great. These clinics sound very exciting, and thank you for the update. Perfect. I don't think we've got any other questions for the floor, but I think we'll get a lot of inquiries about these clinics after the recording goes live. Do you have anything else you want to add there, Joe?
No, I'm sure
Perfect.
Everyone back to their Tuesday evening.
Perfect. Well, thank you so much to all the 3 presenters for giving up your time. We really, really appreciate it, representing Northern Health and Partnerships. And there's been, there's a lot of interest in sort of education, and GPs ask us specifically about women's health, and now we actually have somewhere we can direct them. So really, really grateful for all of your time. On closing, I think Kathy just wanted to mention a few things on health pathways. So thank you to all the presenters. If you guys want to add anything else, you can. Otherwise, I'll get Kathy to talk about health pathways before we close.
Yeah, thank you, Richard. And I'd like to also say thank you very much to all of our presenters tonight. My name is Kathy Tepp. I work for Eastern Melbourne PHN, and just to give you a very short demo on Health Pathways Melbourne. So Health Pathways is it's written by GP clinical editors with support from local GPs, hospital-based specialists and other subject matter experts. It's designed to be clear and concise, to give evidence-based medical advice. It helps in the reduction of variation in care, and it has referral pathways, importantly. So that's the homepage of Health Pathways. It's run by both Eastern Melbourne PHN and Western Melbourne PHN. And we've just highlighted there some of the gynaecology and women's health pages. So on our homepage, you can see latest news and the pathway updates. There's another relevant page on cervical screening. And as you can see, this fertility specialised referral, there's a lot of relevant pages that you could be interested in. And I also just wanted to highlight that you can do some CPD through Health Pathways, and we do have a template there for recording a reflective activity. So that could be helpful for some of our GPs. If you're wanting to get onto Health Pathways and you haven't yet used it, you can go to that website there, or you can use that QR code, and then you can sign in from there. Okay, that's all from us tonight. As you close today, you will get an evaluation. We'd really appreciate it if you would do the evaluation for us, and we look forward to seeing you at our next webinar. Thanks, everyone.
Thanks, everyone. Thanks, Kathy. Thanks, guys.